A small bowel obstruction is the blockage in the small intestines, caused by both non-mechanical obstructions as well as mechanical, with mechanical meaning that there's something physically blocking the GI tract. So for causes and risk, non-mechanical obstruction is from a paralytic ileus, fancy words for a paralyzed bowel. Everything stops and the bowel can die, typically after GI surgery or even opioid use, which makes everything low and slow, especially inside the bowels. And mechanical obstruction, which is that physical blockage from adhesions like scar tissue from surgery, even from hernias, and intusception, where a part of the bowel gets stuck into another, kind of like a telescope. And also from tumors, from cancer, and volvus, basically just a twisting of the bowel. Now, when a bowel obstruction occurs, it develops with both gas and fluid collecting above the site of obstruction, causing a lot of pressure. Kind of like a fat kid getting stuck in a water slide. Like that chubby kid in the movie Willy Wonka and the Chocolate Factory who gets stuck in that chocolate tube. This is not good. So naturally, we hear hyperbowel activity above the site of obstruction and hypobowel activity below the site of obstruction. So signs and symptoms of a small bowel obstruction develop faster than a large bowel obstruction. This is because small bowels are smaller, allowing for more rapid obstruction. So the key point for a small bowel obstruction is rapid onset. So write this down. Frequent vomiting and nausea, as well as abdominal distension, described as colicky, or basically intermittent abdominal pain. Remember, it's a rapid onset, happening quickly. And again, bowel sounds. We hear hyperactivity above the obstruction and hypoactivity below the obstruction. Now, don't let the NCLEX trick you here. Not constipation or lack of flatus, or basically passing gas, which are typically late signs and more common with large bowel obstructions, which develop slower. And not painful pooing or defecating. This is common for rectal problems like hemorrhoids. As for complications, just think of the patho here, like a fat kid getting stuck in the water slide. We have a lot of pressure building up behind this small bowel obstruction. It's kind of like a ticking time bomb. The bowels can explode all over, leading to a perforated bowel, which eventually leaks into the peritoneal cavity, causing peritonitis. Again, this is a medical emergency, very deadly. We cover it in all the lectures pretty much in this GI series. So the NCLEX tips, once again, look for fever, tachycardia and tachypnea, as well as abdominal distension. And a key term here is a rigid board-like abdomen. The client needs immediate surgery or they will die from septic shock, that infection all over the body. So a common exam question. A client with a small bowel obstruction suddenly develops tachycardia, tachypnea, and high fever. What is most likely the problem? So option 2 here, a bowel perforation. You must notify the HCP because this client needs immediate surgery or they will die. Now in terms of treatment, for initial treatment, we do the double N's, NPO and NG tube insertion, to decrease that abdominal pressure and decompress the bowel. So the top 5 tips here. Number 1 is NPO. Number 2 is NG tube insertion, that nasogastric tube. And number 3 is IV fluids to prevent fluid and electrolyte imbalances caused by the NG tube suction. And number 4 is the semi-Fowler's position. Keep that client up. And number 5 is pain control using non-opioids. Write that down. Non-opioids are preferred since opioid analgesics can make the bowels low and slow, worsening the problem. So avoid analgesics that are the opioid analgesics. Just look for the O's here. Morphine, hydrocodone, as well as hydromorphone. We always question any doctor's order or prescription for these drugs during a small bowel obstruction, or even a paralytic ileus. So once again, the memory trick, just look for the O's to know it's an opioid. Morphine, hydrocodone, hydromorphone. Remember, They make everything low and slow because they are opioids. Now, if patients fail to improve, they'll need surgery to cut out the problem area, called a bowel resection. And they may have a placement of an ostomy, like a colostomy or ileostomy, which we cover in a separate video. Alright, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the